Madam, good evening. Madam, please
Hi,
unmute
Sneha.
yourself.
Good evening.
Hi, madam. Good evening. And so sorry to bother you.
No problem.
Yeah. So,
अभी मेरे को
hi,
पहले
Niharika.
I have some guests at home, so
Yeah, I understand, but I just thought, Niharika said, madam, but please, you have the word with her personally. I said, okay, I better call madam.
no, that's not a problem at all. Don't worry. We are always there with you.
Thank you so much. Hello, madam. Good evening. Good evening. Good evening.
Hi,
I'm in
Sneha.
भोपाल में हूँ. हाय भोपाल में हूँ.
Okay. तुम्हारा वॉइस ब्रेक हो रहा है.
I'm in भोपाल.
Hi, Dr. Rashmi. Welcome.
Hello, ma'am. Good evening.
Good evening. Good evening. Hello. Hello, Dr. Sushma.
Thank you, ma'am.
Good evening.
Hi, Sushma. Hi, Rashmi. Hi,
Hi,
Niharika.
ma'am. Hello, ma'am. Good evening.
Hi,
How are
Milind.
Hi,
Hi,
Milind.
how are you, Jaideep?
All good, all good. How are you all doing?
Yeah, in OT.
What में है?
I'm dealing with all those comments, Sholapur. Yes. We people always work and work.
I
खत्म ही नहीं होता. Yes. How the things are?
Very good, very good. God's mercy.
Great. Hi, Sneha. How are you?
Hi, Milind. I did say hi to you. Hi.
Great.
Hi, Rakhi. You are
Hi,
still,
Dr. Milind.
yeah, you are still
Hi.
in OT, is it?
Yeah, I'm still in OT. The cases are going on. Today, Atisha has come, na, so a lot of
Yeah.
endoscopy.
Your
Okay,
2
Bella
days
and Atisha are
hectic
here. Yeah.
marathon.
They're very much here saying, Bella is saying hello to
Yes.
you.
Hi, Bella. Hi, Atishay.
Hi, Bella.
Great, yeah.
हाय बेला, मैं एमपी में हूँ.
Oh, hi.
Yes, I know. I just saw your post. You are in Sagar, I suppose.
Yeah, now
Great.
reached to Bhopal for the night CM in Bhopal. आ रही हूँ
Wow.
तेरे इंदौर में. आ
Oh
रही
my
हूँ तेरे
God.
इंदौर में.
Today, they are here to do a lot of scopies today. Yes, yeah.
Hi, Niharika. So, I think Shela is also joined.
Yes.
Yeah.
Good evening to all.
Hi, dear Snehala. Thank you for helping
Inshallah.
Neha.
But see, once again, Shehla.
Hi, Shaila.
Shehla is always being addressed as Sneha or Snehala. So, hi, Rakhi.
Hello, ma'am.
Hello. Welcome.
यार राखी कितनी फ्रेश दिख रही है तू.
नहीं, it is the effect of that background.
ना ऐसे स्विमिंग पूल से बाहर आई हुई फ्रेश ऐसे लग रही है एकदम. I had a temptation, I'm watching from my window the swimming pool here. I have so much temptation to enter there.
Hi, Rakhi. How are you?
Good, sir. Hello. How are you, sir?
I'm great. Yeah.
Hello, ma'am.
How are you?
Good.
नेहारिका तू कैसे मैनेज करती है यार ये सब कुछ. कैसे
Ma'am,
मैनेज करती
no
है. कहाँ
comments.
थी?
तुम कैसे करवा लेती हो इससे सुनीता?
बहुत अच्छे से करती है निहारिका.
नेहारिका
तुम सब करवा लेती हो.
Yes.
Niharika is fantabulous.
Welcome, Gorak. Good evening.
गुड
Hi,
इवनिंग
Gorak.
हेलो मैडम कैसे हो आप?
Hi. बहुत बढ़िया.
So,
You're looking
चलो
tired,
स्नेहा
Dr.
start
Sunita.
करते हैं. No, you know what? Whole night traveling. We just went to Sagar. No, early morning 5 बजे. We have just entered the room. We have now night CME in Bhopal.
Okay. All on wheels. Continuously.
Enjoying.
Plus webinar
yes,
both together.
that's what I have written. Enjoy the journey.
Enjoying.
Yeah, the journey is
For-
more enjoyable than the rest of it.
Yes.
I can.
Yes.
No, and this time I have Kundan, Ashwini, everyone who traveled with me from Pune. So it's a
Lovely.
fun. We are doing like a dhabe pe ruko, chai piyo, ice cream khao.
You know, the journey, I didn't mean that. I meant the journey to the chair.
Yes.
Yeah.
Enjoyable.
Enjoy.
It has got
Journey to-
its own charm, I feel.
You will enjoy it. Don't worry. Next year.
No, 20, राखी का year 2025 है.
डर लग रहा है सोच के.
No, तू मेरे साथ रहने वाली है.
Okay, hello, ma'am.
Hello.
Can we start?
Yes.
Yes.
That is what I was about to say. I think all our guests have joined. We can start. No.
So, I, Mehul Doradia, on the behalf of Corona Remedies Private Limited, welcomes you all the faculties and delegates for the Core Connect live webinar initiated by the Amogs Medical Disorder Committee associated with the Agra, Noida, Greater Noida, and Mathura societies. So, for this live webinar, it's my great pleasure to welcome our MOC and coordinator, Dr. Niharika Malhotra. So, Dr. Niharika Malhotra is the gold medalist and has done DRM in Germany and fellowship in reproductive medicine. So, Dr. Niharika is associated editor of Human Reproduction Journal and joint secretary of FOXI and currently she is a chairperson of YTP committee. And she is also a member of very international societies like Aspire, ESRE, RCOG, ISOPAB, ISPET. And Dr. Niharika awarded by many prizes and also presented papers and posters in various journals. Another great thing is that Dr. Niharika is a social worker also, and she runs an NGO, Smriti, for the girl education and women empowerment. So, so I welcome Dr. Niharika Malhotra and request you to please take forward this webinar.
Thank you so much, and namaskar and a very good evening to everyone here. Welcome to yet another learning activity by Amogs, which is associated with Agra, Noida, and Mathura Society. We all understand that education is one of the most powerful weapons which can change the world. And as doctors, we also know that we need to keep updating to give our best. And I think this webinar series which has been happening is the best way to keep our knowledge updated. And we highly thank Amogs and ICOG for conducting these webinars regularly. With this, I would also like to invite all my faculty present here to begin this program with the lighting of the lamp. We have with us our guests, Dr. Jaideep Malhotra, Dr. Sunita Tendulwadkar, and Dr. Milind Shah, and ICOG office bearers, Dr. Lakshmi Srikhande and Dr. Ashok Kumar. I invite all my faculty for lighting of the lamp.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
To this program, I would also now like to invite the conveners for the same. Two conveners for today's program is Dr. Rakhi Singh and Dr. Vartika Kishore. And we know Dr. Rakhi Singh and Dr. Vartika Kishore, one of my favorite people in Foxy, and I have been very closely working with both of them. Dr. Rakhi Singh is the chairperson of Endocrinology Committee of Foxy, vice chair of the UP State ISAR. She is also peer reviewer of Journal of OBGYN Joki and has numerous awards and achievements under her credit. Welcome, Dr. Rakhi. We also have with us Dr. Vartika Kishore. She's the past president of the Mathura OBGYN Society, a very active member for the Safe Motherhood Committee, also advisor for adolescent health for the Society of Menstrual Disorder, and a Manyata trainer for project under Foxy. We welcome you here, Dr. Vartika. I would also like to introduce the brainchild behind today's program, Dr. Sneha Buyar, who has been actively working to spread awareness and education through various platforms. So Dr. Sneha Buyar has multiple awards and accolades to her credit and has given more than 300 talks in state and national and international conferences. She was the chairperson of the Breast Committee of Foxy 2019 to 2021 and is a governing council member of ICOG. Also now the chairperson of Medical Disorder Committee of Amogs. Welcome here, Sneha ma'am. And I now invite Dr. Sneha ma'am to introduce our guests.
Thank you so much, Dr. Niharika, for that wonderful, I would say, kind and generous introduction. You can stop sharing, Mehul. A very good evening to all the respected guests for today's program, Madam Jaideep Malhotra, my mentor. Looking at her, I have climbed the steps on the way of Foxy. And Madam Sunita Tandulkar, also Dr. Milin Shah, who was my mentor for ISOPUB, President Amogs, Dr. Rajendra Singh Pardesi, Secretary General Dr. Sujata Davi, all the President and Secretaries of UP Society, Dr. Sushma Gupta, Dr. Poonam Yadav, and of course Dr. Rashmi and Dr. Sadhana, Dr. Sanchita Dubey, and Dr. Aradhana Singh, Dr. Shweta Mathur, of course, Dr. Diti Mathura as well. All the esteemed faculties, my dear friend, Dr. Gorak Mandrupkar, who was also the chairperson of Medical Disorders Committee of Foxy, and he's the speaker for today's program. So I welcome all of you here. A very good evening to all of you. And I take this opportunity to thank all of you for having us here, being associated with us and giving us the opportunity to have close interactions with you. So as Niharika has very rightly said, that education is the most powerful weapon you can utilize to change the world. Definitely, I believe it so. And with this motto, we have been covering almost the whole of India, you can say, and we have been designing and executing the programs on various aspects of medical disorders of pregnancy. And today's topic we have chosen the less covered ones myself, the cardiac diseases during pregnancy, the changing trends, and Dr. Gorak will cover the topic of thyroid disorders during pregnancy. We're going to, this time we have decided a little different, a quiz on the medical disorders of pregnancy, which Dr. Shehla and Niharika is going to be the quiz masters, and Dr. Sushma and Dr. Rakesh Singh will be the judges for this. Once again, I welcome all of you, and to go ahead with the proceedings, I hand over to you, Niharika, once again. Thank you so much. And I think before Niharika says something, I would like to invite today's guest, the first guest, and of course, as I have said, my mentor, my advisor, right from the beginning, Dr. Jaideep Malhotra, a big name, not only in Foxy, just named the organization, and she has headed it right from ISPAT, ISAR, and even I think now she's the chairperson for FICO also. So without reading this CV, I would just like to mention that Madam is a very good mentor. She can actually handhold and she encourages you so much that somebody has said that the leader is not one who makes lots of followers, but the leader is one who creates lots of leaders to follow. So with this, I hand over to you, Madam Delhi Malhotra, and we are eager to listen to your precious words. Over to you, Madam.
Thank you, Sneha. Thank you so much. And a very good evening to all of you, my friends from my own state of Uttar Pradesh and my own city also, and from all over the country. I mean, I have all these beautiful people on the screen whom I have an association, a very beautiful association for not a few years, but few decades, I would say. So I can't name each and every one of you, but each of you of whom I can see on the screen are very, very dear, and I really love you. And thank you again, because this is a topic, Sneha, which all of you have chosen. It's a really important topic. I've just come back from Cape Town from the IMNCH meeting, which is like, the International Organization on Maternal, Newborn and Child Health, which is a part of PMNCH and WHO. And we had extensive discussions on maternal mortality and neonatal mortality. And the conclusion was that unless and until we are able to actually control this particular area of our branch, which is medical disorders in pregnancy, we will not be able to bring down the maternal mortality as much as we are expecting to. That's a very, very, very important aspect which all of us have to learn. And today, when you were talking about cardiac disease in pregnancy, and I was remembering my mother-in-law, she would always auscultate. And I have not seen any of our youngsters actually auscultating a lady who comes in pregnancy. And that's another very important problem, where we miss out on a lot of, these diagnoses early, especially in the preconception or otherwise. And we need to pay a lot of attention to them, whether it's thyroid disorders or, the other NCDs which are there. All of them have repercussions not only on the pregnant lady and the baby, but on the future 2 generations. And I feel actually really, proud that you have taken this up. I also feel that, my project of Adbhut Matratva basically focused on these, because we need to bring these down. And then only, and each one of them has, repercussions on preterm birth. Many of them have preterm births. Preterm birth has associations with cardiovascular disease. So there are a lot of integration and interrelation between these medical disorders. So I would really, expect that the speakers today discuss the topic at length, not only about, the pathology and the management, but the repercussions, the long-term consequences, which are very, very important for our youngsters to understand. Thank you very much for having me here. I am absolutely thrilled to be with all of you, and all the best to each and every one of you in your future endeavors. Thank you.
Thank you so much, Madam. Thank you so much for your blessing. Over to you, Niharika.
Thank you so much, ma'am. And I would now request Dr. Rakhi to introduce Dr. Sunita Tandulwadkar, ma'am.
Thank you, Niharika, and thank you, Sneha, ma'am, for taking me into this webinar and giving me the opportunity to introduce the Queen, that is Dr. Sunita Tandulwadkar. She is head of the Department of OB-GYN, IVF and Endoscopy Center. And we've seen her hopping day in and day out for her presidency, and wish to see you as a president also. She has been the advisor consultant at DY Patel IVF Endoscopy Center, Pune, founder and medical director of Sono IVF Clinic, founder medical director of Sono Stem Cells. And we had an opportunity to see the launch, which was there done on Saturday evening at the inaugural ceremony of the program of Star Global, where the Ovarian Rejuvenation Society was launched by Dr. Sunita as a president, which is not there on the CV. I would like to read out those things. And here I present to you, Dr. Sunita, the global person, the star person.
Thank you. Thank you, Rakhi. Thank you for your kind words. I think the CV gets also hopping up from one WhatsApp group to another WhatsApp group and I definitely will correct that CV. First of all, this idea, Sneha, congratulations and thank you for having me. This idea of medical disorders of pregnancy is really the need of our hour. And you have aptly taken 4 societies like Agra, Noida, Greater Noida, and Mathura. I was with Mathura Society yesterday. I see Aradhna here. And Rakhi, you introduced me to Aradhna, the dynamic lady. And I still remember that evening in Noida. So I think this webinar has brought us definitely together on a personal level with all the gynecologists, but at the same time, academically, definitely it has helped. If I can't see now, I can't hear now, I can watch, I can go here, I'm traveling here and there, I just go to the conference site and I can hear so many important, interested lectures and educate yourself. Believe me, definitely it is helping from the youngsters to the elders in the same way. I won't say ki the webinars, of course, some webinars are the same, but some educative webinars have become really popular and I'm looking forward to it. Gorakh and Sneha, Sneha, both of your talks are vibrant talks. Though I know at 7 o'clock I'm starting my own physical CME over here, but adding the quiz and having the 6 quiz partners, it means those girls are probably ready to answer. I like this idea. And Neharika, thank you so much for always getting in with the novel idea. And Shehla, you have been very bright to be with her. I hope I pronounced you right. I'm so thankful for having me over here with Jaideep Malhotra as one of the guest honor and Milind Shah, another my dear friend, as another guest of honor. Lovely to see that he's working till late in the evening in the operation theater. I'm missing it sometimes.
Thank you so much, Sunita ma'am. It's always a pleasure to have you and take your blessings. And you are an inspiration to all of us. I now invite Dr. Vartika. Dr. Vartika, if you're here, I would request you to introduce our guest, Dr. Milind Shah.
Good evening, everyone. I would like to thank Sneha ma'am to having me here, and I welcome Dr. Milind Shah sir. Who doesn't know Dr. Milind sir? He is such a down-to-earth and ever-smiling person, and it's always a pleasure listening to sir. Sir has been past President ISOPAR, President IMA Solapur branch in 21-22. He has been founder president of Infertility and High Risk Foundation, honorary secretary general, FAOPS, vice president of WOTC. He has held many important portfolios. He's been second vice president of SPARC, deputy general secretary general in SAG, ex-chairman Rural Obstetric Committee of WOTC. He has been managing committee member IAG, SAN, FUMP, IMLEA, and peer reviewer for General Obs and Gynae of India. Sir has visited n number of countries around the globe to deliver his lectures on various topics in Obs and Gynae, and authored many important chapters and many important books. And Sir, above all, is also an active Rotarian. I welcome Sir to this prestigious webinar. And Sir, please say a few words. I invite Dr. Milind Shah.
Thank you very much, Dr. Vartika, for all these kind words. In fact, I understand that it is such a wonderful, actually, academic deliberations we'll be having today. And I must say big thanks to Dr. Sneha Puyar and Dr. Sunita, who are doing such a wonderful work actually in this field of academics that I'm very sure all those clinicians, especially those who are practicing at the far end at district places as well, are going to get benefited when they understand about these various medical disorders and all those nuances. Just now, Jaideep told about auscultation. Yes, very true. That has been taught in each and every college, and that's so important because now we have realized that one need to tell all those clinical tips and tricks whenever we are dealing with these medical disorders, and which can definitely take us to a far greater level when we deal with the services given to our women. I must say big thanks to all Amogs office bearers, ICAG office bearers for giving this wonderful opportunity. Uh, I'm thankful to all my actually the co-guests of honor, Dr. Jaideep and Dr. Sunita, very close friend. I must say big thanks to all these presidents of various societies who are participating. Sushma, a close friend, Aradhana, and Sadhna Jaiswal, as well as Jyoti. Because I know that all these presidents, secretaries are going to do a good work as far as their society members are concerned. Because I always met Poonam, Shweta, Samta, as well as Rashmi on various platforms, and I realized that we definitely can do a lot of things. The coordinators are the pillars of any webinar. I know Niharika and Vartika because you were so good, as well as Sheila and Niharika as well, because they always and always do a lot actually when it comes to their responsibilities. Coming to the various topics, I'm very sure what Gorak and Sneha are going to speak is going to go a long way, and even the quiz will be something really wonderful, whereby we also can learn even at this age about this particular fact. So thank you very much, guys, for this wonderful opportunity. I know that I could not actually give a lot of time because of the OT, which is still happening, but I'm very sure this webinar is going to go a long way as far as spreading the knowledge is concerned. Thank you very much.
Thank you so much, Milind sir, and thank you to all our guests for blessing this wonderful webinar today. I would also like to thank the Agra, Greater Noida, Noida and Mathura Society for being an active part for today's series. And we would now like to begin our scientific session. For the first session, we will be covering cardiac problems during pregnancy and what are the recent changing trends. And for this session, our speaker will be Dr. Sneha Bhuyar. I would now like to invite the chairpersons of our first session, Dr. Rashmi Goyal. Dr. Rashmi Goyal is the Secretary of Mathura OBGYN Society. She's the Director of Rashmi Hospitals Mathura and also the owner of Unnati Ultrasound Center Mathura, and has been awarded 3 times by the Health Minister of UP for being the best gynec surgeon. We welcome you here, Dr. Rashmi. Our next chairperson for today's session is Dr. Sanchita Dubey. She's Senior Consultant OBGYN Apollo Hospital, Noida, Delhi NCR. Also the Director of Evidence Healthcare Clinic, Noida, Vice President of the Noida OBGYN Society, and also been the Honorary Secretary and Executive Member. She's been actively participating in FOXI and has been an active member on the HIV/AIDS Committee. We welcome you here, Dr. Sanchita, and I would now request Dr. Rashmi to introduce the speaker.
Thank you so much, Dr. Niharika, for the kind introduction.
Thank you so much, Dr. Niharika. It is my great pleasure to introduce Dr. Sneha ma'am. Everybody knows her. She is a very dynamic personality. She actually need no introduction. She is a MBBS MD, both from BGMC, Sasun Jain Hospital, Pune. She is Managing Director of and Maternity Hospital. She has a 29 year of experience in the field of teaching, in 5 years of SNB Government
Yes,
Medical College.
Thank you so much, dear. Thank you. I think I have been already introduced. I just got disconnected in between, so I have just managed to join it. I just take this opportunity once again to thank all of you and straightway go ahead with my talk. My topic for today's is cardiac problems during pregnancy, the changing trends. I hope you can see my screen. Uh, Niharika, chairpersons, can you see my screen?
Yes,
Yes,
ma'am.
madam.
Yes. So, friends, cardiac problems during pregnancy, the changing trends, that is the topic for today's. Uh, when I was a child, I thought the heart looked like this. And one day the teacher drew the diagram like this. Is this the change? No. Jokes apart, heart disease during pregnancy, all of you know, though not very common nowadays, it still complicates almost 1% of all pregnancies. As all of you know, that pregnancy per se brings about profound physiological changes in the body and especially in the cardiovascular system. And because of these changes, the symptoms and signs they mimic heart disease. So on top of this, if the woman has pre-existing heart disease, it will worsen the pregnancy outcome, which will affect the maternal as well as fetal prognosis. So what are these physiological changes and how do they take place? These physiological changes, they may start as early as 6 weeks of pregnancy. They continue to grow, continue to reach its peak by 30 to 32 weeks of pregnancy and throughout pregnancy, labor, delivery until 2 weeks post-delivery. So what are the problems or complications in the fetus and in the mother? For the fetus, it can result into spontaneous abortion, prematurity, fetal growth restriction, intrauterine fetal death, and long-term complication as congenital heart disease to the tune of 5% for the fetus. The maternal complications, as all of you know, cardiac failure, bacterial endocarditis, pulmonary edema, pulmonary thromboembolism, polyhydramnios, preterm labor, and postpartum hemorrhage. So all of you know that the blood volume increases to the tune of almost 20 to 40%. So there is this reaches the peak by 32nd week, as we have already said, and because of this, there is a increased preload on the heart. The afterload decreases. That is because of multiple factors, and one of them is the growing uterus compresses the inferior vena cava, leading to stasis of the blood in the lower extremities. At the same time, you have increased venous capacitance because of the progesterone hormone, and also, you know, the placenta acts as AV malformation or the AV shunting. So the cardiac output increases by 10 to 20%. The heart runs faster by 10 to 15 beats per minute. There is also changes in the blood pressure. The systolic blood pressure rises by 5 to 10 millimeter of mercury and decreases by 5 to 10 millimeter of mercury, and diastolic blood pressure decreases by 10 to 15 millimeter of mercury. And this, as we have discussed, because of the various changes. There is an increased tendency to the varicosities. The reasons we have already discussed: the vena cava compression, the increased venous capacitance, and the AV shunting because of the placental reason. So these are the cardiovascular changes which happen during normal pregnancy. The plasma volume increases by 40%, the cardiac output increases by 43%, heart rate 10 to 17 per minute, mean arterial pressure by 4 millimeter of mercury, the stroke volume rises by 27, the systemic vascular resistance goes down by 21, and pulmonary vascular resistance goes down by 34. So these are the various changes in pregnancy. And because of these changes, most of these women may develop fatigue, shortness of breath, decreased exercise tolerance, and of course, palpitation. So sometimes she may develop peripheral edema, distended jugular veins, even audible systolic murmur, what we label is at the breast brood. So this is explained by the changes which occur right from the early pregnancy and they peak in the second or late second trimester. So if the changes which are physiological mimic that of the cardiac disease, Then how do you go ahead with the diagnosis of the organic heart disease? Of course, careful history taking, detailed examination, as Madam Jaideep Malhotra just said, that you must auscultate each and every lady who comes to you for examination of pregnancy or otherwise, and of course the further investigations. So how to differentiate between the physiological changes, the symptoms and signs of physiological changes of pregnancy and the organic heart disease. So during pregnancy, because of the physiological changes, the woman just feels weakness, fatigability, easy fatigability, I would say, breathlessness, syncope, tachycardia, and the blood pressure may be just marginally low. The heart sound, the first heart sound is split, the apex is deviated to left and little upwards. There may be a systolic murmur, which is mild, that is less than 3/6. Uh, Whereas for heart disease, you have progressive dyspnea, orthopnea, the paroxysmal nocturnal dyspnea, chest pain, nocturnal cough, or hemoptysis. But definitive signs like cyanosis, clubbing of fingers, persistently distended neck veins, the systolic murmur of more than grade 3/6, or diastolic murmur, persistent arrhythmias, and the persistently split second heart sound, and evidence of cardiomegaly. These are the definitive signs which would differentiate the physiological from the pathological or the organic heart disease. So what are the investigations? The routine investigations, apart from the blood hematological investigations, we have certain enzymatic studies, that is troponin 1 and CPK enzyme studies. The X-ray chest will show you the cardiac size and the outline. ECG will tell you about the rate and rhythm, maybe ST elevation also, and the left axis deviation if there is a left ventricular hypertrophy. Of course, the 2D echo will definitely tell you about the structural changes and will tell you about the cardiomegaly. In certain conditions, maybe the angiography may be necessary. So once you have the history, the careful clinical examination, various investigations to confirm, and once you come to the diagnosis of the organic heart disease, so when your patient has this pre-existing morbidity, then you have to categorize this patient as per her etiology of the heart disease, the functional classification, and the severity of the grading. So the etiological classification is congenital or acquired. You have congenital non-cyanotic, that is ASD, VSD, PDA, and cyanotic as Pallostetrology and Eisenmenger syndrome. Rheumatic heart disease, which was once upon a time very common, MSMI, ASAI. The cardiomyopathies, especially the peripartum cardiomyopathy, ischemic heart disease, and other heart diseases like syphilitic hypertensive or the thyrotoxic heart disease. Coming to the functional grade, that is NYHA classification. Grade 1, you have no limitation of the physical activity. The patient can perform a regular activity. Grade 2, mild limitation of physical activity. That means with slight, the patient can go for the mild limitation of physical activity. That is symptoms with normal physical activity. Marked limitation of physical activity, that means she gets symptoms even with less than normal activity. She's only comfortable at rest. And grade 4 is severe limitation of physical activity. She is symptomatic even at rest. Coming to the severity grading, low, medium, and high risk. Low risk, these are only 0 to 1% of the cases. Here comes the acyanotic or non-cyanotic heart disease, and of course the corrected Pallostetrology. Medium risk, this contributes to almost 5 to 15% of the heart disease. And here comes the mitral stenosis, grade 3 or 4, and mitral stenosis with atrial fibrillation, aortic stenosis, and uncorrected Pallostetrology. High-risk cases, here you have primary pulmonary hypertension, Eisenmenger syndrome, aortic coarctation with valvular involvement, and Marfan's with aortic involvement, that is aortic aneurysm formation. Rheumatic fever, which was once upon a time, as I said, was very common. I'm sure 30 years down the line, we have seen many cases of rheumatic heart disease. We have managed them actively. But because of the early diagnosis, because of the early recognition, the effective antibiotics, the rheumatic fever is detected and treated at the earliest and it is not allowed to progress beyond fever, sore throat, and even polyarthritis. So the presentation of pancarditis and then the inflammation of the heart valves leading to scarring, leading to cyanosis or rigors doesn't happen now. So this, thanks to the antibiotics, we do not have to see such kinds of cases. Coming to congenital heart disease, as we have initially just mentioned about acyanotic and cyanotic heart diseases. So acyanotic is usually you have left to right shunts. So when this shunt progresses and the pulmonary vascular resistance increases to such an extent that the right-sided pressure becomes more, and there is reversal of shunt, that is right to left, what we label is as Eisenmengerization. So when this happens, then this is the worsening of the situation and it becomes a cyanotic heart disease. Here you can very well see the various kinds of defects as we have mentioned here. The atrial septal defect, this is the normal heart, and this is what the atrial septal defect you can see here. This is the normal heart once again, and here is the atrium, ventricle, and ventricular septal defect. So likewise, you have the patent ductus arteriosus here, and of course the mitral and aortic regurgitation. So coming to the cyanotic heart disease once again, the tetralogy of Fallot, that is the ventricular septal defect, right ventricular hypertrophy, the pulmonary stenosis, and the overriding of aorta. So previously, these patients, they used to succumb in their early adolescence, and they were not able to reach to the childbearing age group. But because of the effective and successful corrective surgeries, these population is now reaching the childbearing age, or they are going ahead with their obstetric career, and that's the very reason we are getting them quite frequently as patients who have undergone the corrective surgery. Coarctation of aorta, that is narrowing. So it usually involves the aortic arch, and when it involves the valve, it becomes very high risk. So as we have discussed, that coarctation of aorta involving the valve becomes the high risk case. So high risk is grade 3 severity, where we can't allow the woman to conceive. This is what is meant by the narrowing of the aorta, coarctation of aorta. Sorry. A hereditary, this is about the Marfan syndrome. Marfan syndrome is nothing but a connective tissue disorder where you have a very thin, tall lady with long extremities, the disparity in upper and lower segment, and you have hyper flexible fingers and toes, and they have typically the scoliosis. And then, of course, they have the involvement of the aortic. When they have the involvement of heart, they usually have the mitral valve prolapse and the aortic aneurysm. That is why when you have such kinds of patients, you have to be very cautious and examine the patient, auscultate it thoroughly, and get her evaluated. Sometimes, yes, considering the demographic changes, the elderly ladies coming with pregnancy, of course, the obesity and the lifestyle changes, we are getting a population who is at a high risk for developing the myocardial infarction or ischemic heart disease. And this is occurring because of the high levels of cholesterol, that is the LDL, and the high level increase in the cholesterol, the low density lipoprotein, and decrease in the high density lipoprotein. So the best cardiologist surgeon in Hyderabad, this is just to quote that the evidence 1 in 10,000 may affect this during pregnancy. Here you can see the atherosclerotic plaque or the lipid deposit causing narrowing and obstruction of the coronary vessels. So the causes was previous pregnancy with complication, underlying renal or heart diseases, rheumatic illnesses, and a history of previous blood clot. As I have mentioned about the lifestyle, have a look at this picture just to show you we gynecologists cannot have this view that whether you want the baby or bottle and you have to really stop drinking, but not to be judgmental. You can at least try and counsel that she has to cut short or minimize on her alcohol intake, she has to reduce on her smoking, she has to manage her diabetes and her blood pressure, she has to optimize her weight and BMI, and she has to get investigated, evaluated at the earliest rather than waiting for severe chest pain, breathlessness, and weakness, so that things become so late that when she starts getting nausea, vomiting, and severe chest pain, tachycardia, various kinds of arrhythmias, before that she is supposed to get evaluated herself and should be managed accordingly. So when you have such kind of patients, which are quite common nowadays, we have to actually hospitalize the patient at the earliest, monitor the patient's vital signs, see her level of mobility, consciousness, monitor her fetal status, her of course, you have to manage this emergency first, and then, of course, we have to go for counseling and other aspects of lifestyle management. The patient has to be kept in the left lateral recumbent or semi-recumbent position to minimize the aortocaval compression. Oxygen is to be administered, and we have to see that we are not giving lots of fluid. The fluids have to be restricted. We have to watch the patients carefully for her vitals, monitor her oxygen saturation. By the time you can just give her diuretic and start her on mechanical ventilation if needed, if she's got severe pain. This is just to mention some kind of analgesics, and meanwhile you have to call the cardiologist, and we have to manage the patient under his supervision and guidance. So definitely once she comes out of this, then managing the cholesterol levels, improving on the good cholesterols, improving on her lifestyle, that is food and the physical activities definitely. So the point here is whether we should allow the patient to come as emergency, or even if a registered antenatal case, if at all you miss her history or detailed examination at her early antenatal visits, maybe she may land up into the emergency. And that's the reason at the very first antenatal contact, we have to thoroughly examine this patient in addition to the thorough history. So should we allow our patients to land up into emergency, or should we have preconception counseling for such patients? As I have already talked about, certain cases like grade 3 severity, that is primary pulmonary hypertension, Eisenmenger syndrome, Marfan's with aortic involvement and coarctation of aorta. These are the cases where we should not allow them to conceive. If at all they conceive, we have to go for early first trimester abortions or MTPs, because MTP per se, if it is done in second trimester, that will also be a risk to life. Maternal mortality varies directly with the functional classification at the onset of pregnancy, and that is why during pre-pregnancy counseling itself, even if whether the lady has this morbidity, that has to be diagnosed and evaluated. If she has this comorbidity, it should be optimized by medical and surgical treatment. The counseling regarding the maternal risk, the prognosis of the pregnancy, the social and cost consideration, hospital delivery, preferably at tertiary care centers. All these things have to be explained. If at all this high risk lady conceives, I have already said she has to undergo first trimester, that to early first trimester MTP. Antenatal care, the clear counseling of risk and prognosis has to be done. For other women, maybe we ask to come for follow-up every monthly, but for this lady, at least every 2 weekly, we have to call her for follow-up. On every visit, you have to note not only the vitals, but also the symptoms, the cough, dyspnea, edema, etc. And we have to monitor her blood pressure and weight very carefully. We have to auscultate her lung basis and re-evaluate at each visit for the functional grading. Ensure the treatment compliance, that whatever treatment you are giving, she's following. Exclude fetal congenital malformations by level 3 ultrasound and also fetal liquid. 20 to 22 weeks, and fetal monitoring has to be an ongoing process. We have to give her adequate rest, avoid undue excitement, that is physical and mental stress, diet, the supplementation of iron and vitamins, hygiene, especially any sort of infection in the body, should be treated promptly to avoid the endocarditis, and of course, dietary salt restriction, avoid smoking, and the drugs like beta mimetics, early diagnosis and treatment of hypertensive disorders of pregnancy, diabetes mellitus, therapeutic and prophylactic cardiac interventions if applicable. Previously, for the recurrence of rheumatic fever, benzathine penicillin 12 lakhs every 3 weekly, diuretics, beta blockers, digoxin, anticoagulants, as per the advice of the cardiologist. Surgical treatment if applicable, that means if she's got a critical mitral stenosis, then maybe the balloon valvotomy before planning the pregnancy. Quit smoking, as we have already talked about this, definitely smoking alters the outcome of the pregnancy, may it be fetal or maternal. Hypertensive disorders, I have already talked about. The blood pressure has to be optimized, and it per se is a separate topic. We have to take one more program on this. Definitely, she has to consume lots of fruits and vegetables. She has to consume the minimally processed food, drink lots of water, and she has to maintain her lifestyle very healthy. She has to go for optimum moderate exercise, maybe 30 minutes per day. She has to avoid mental and physical stress, and she has to take care of her cholesterol as well. We have talked about diabetes and what are the point of time whether she needs hospitalization. So if the patient is from NYHA class 1, she has to be hospitalized only 2 weeks prior to her expected date. But if she is class 2, then that means she's having some restriction of the routine activity. At 28 to 30 weeks, she needs to be hospitalized. But if she is from class 3 or 4, irrespective of the period of gestation, the moment she is diagnosed, she has to be hospitalized, evaluated, and managed accordingly. So, whenever the patient who is on anticoagulants, if during early pregnancy she's to be put on heparin, or maybe she has to be changed to other anticoagulant at 36 weeks, deterioration of any time during because of the deterioration in the functional grade, any time worsening of symptoms, indications of complications like fever, persistent cough and basal cramps, tachyarrhythmias, and of course infections, hypertension, abnormal weight gain, all these conditions, she needs to be hospitalized. When we have talked about the bacterial endocarditis, when she it needs to be given, she's to be hospitalized. So the preferred drugs nowadays are ampicillin and gentamicin. In cases where the woman is sensitive to hypersensitive or allergic to penicillin, vancomycin or clindamycin and gentamicin can be given. It has to be an institutional delivery, preferably a tertiary care center delivery. There's no role for induction of labor. It is only for obstetric indications. Per se, for heart disease, she doesn't need induction of labor. Oxytocin, if at all required, oxytocin is the preferred choice, that to the highly concentrated oxytocin, and of course the intracervical Polis with the PGA2 gel, these are the preferred methods for induction of labor. During labor, she has to remain confined to bed, preferably in a propped up or semi-recumbent position. Continuous oxygenation has to be given. She should not face lots of pain. Epidural analgesia may be preferred. The IV fluids have to be restricted, and we have to stop anticoagulants at least 24 hours prior. Digitalizer if she is into failure. Diuretics if she has pulmonary congestion, and deriphyllin if she has bronchospasm. Prevention of infective endocarditis we have already taken care of. Cardiac monitoring, various maybe sometimes you may need the catheterization as well if the cardiologist feels so. Evaluation by the anesthetist and cardiologist is needed. During second stage, the patient has to be in proper position and she should not do undue bearing down, unnecessary bearing down. Preferably, we have to cut short the second stage of labor. Try and avoid the methergine and bolus dose of methergine or oxytocin. Third stage, we have to go for the active management of third stage of labor. Should keep 10 units of oxytocin intravenously, slowly, or intramuscularly. And of course, all these measures to be continued, and we have to immediately after delivery, this is a time where she can land up into congestive cardiac failure or pulmonary edema. So we have to really keep an eye, close monitoring for this, and then we have to tackle accordingly. First few hours after delivery, they are very, very important because the venous return increases suddenly. And of course, because of the ergometrics also, there is a sudden load of the afterload increases. And that is why we have to really keep watch on the signs of pulmonary edema. We have to give prophylactic antibiotics again. What are the indications for LSCS in such cases? As far as possible, if she delivers vaginally well, but there are few indications like coarctation of aorta and Marfan syndrome with dilated root of aorta, where you have to take a for cesarean section. And in this case, you have to prefer the epidural analgesia. Coming to the last point of my presentation, the peripartum cardiomyopathy. Suddenly, a patient, this can happen either during the late third trimester or maybe few months after delivery. The patient just feels weak and fatigued and tired, and she may sometimes feel breathless, and these symptoms become progressive. All of a sudden, you find that the patient who is just delivered having these symptoms, and if you neglect at this point of time, maybe she can worsen anytime. So usually these are the elderly women who have had mild hypertension, they're obese, maybe they have had diabetes and not managed so effectively. So this is actually a dilatation cardiomyopathy, but some hormones like prolactin, SFLT, they are supposed to play some role in this. Whether this can be prevented, yes, effective, not completely, but to some extent it can be definitely prevented. Maintaining healthy weight, healthy lifestyle, optimizing control of diabetes and hypertension is said to reduce the risk of all this. And of course, the elevated brain natriuretic peptide is diagnostic of this. Prevention, early recognition, and supportive management is the key. Advice, avoid infection and continuous monitoring with, of course, the vigilant monitoring for the symptoms and signs of failure. Contraceptive advice, barrier preferably, but yes, the intrauterine contraceptive can be advised for this patient rather than the hormones. It is supposed to be MSc grade 2, MSc class 2 contraceptive. So friends, the gray picture, if we actually have the appropriate knowledge about this, if you do the preconception counseling, if you evaluate your patient carefully, predict, prevent, and manage the complications effectively, I think this gray picture can be converted to such rosy picture. So we have to keep a very high index of suspicion and manage as a team approach. With this, I thank all of you for your patient listening, and I thank once again all the societies for the opportunity. Thank you so much, all of you, and over to you, Niharika and Shaila.
Thank you so much, Neha ma'am, for such an exhaustive lecture covering all about cardiac disorders. And I now would invite our chairpersons to give the concluding remarks. Dr. Sanchita.
Dr. Neha, congratulations for a very, very comprehensive, clearing all the doubts, which I would like to reinforce that history taking, examination, understanding the physiological changes at times, the patient comes with certain problems which are normal features of changes of pregnancy. But yes, you need to identify that if a patient is constantly complaining of certain things, you need to auscultate her, you need to diagnose. So early diagnosis is key to it. And of course, preconception, if any woman approaches you in a preconception period, that would be the best thing to diagnose any heart disease so that you can guide her how to go about it and how to be careful about it. Then there are certain duration of pregnancy where the cardiac volume increases. So you have to be very careful and constantly guide her on those points. And at the same time, a multidisciplinary approach is very important. You should always, a woman should always be in consultation with a cardiologist also for her regular changes in the heart, so that in case there is any additional of the dosage, any medication required, or any further investigations. And of course, at the end, after delivery, that's the most important period where again there's a lot of cardiac volume changes. So you have to be very careful post delivery, and then, as you mentioned, peripartum cardiomyopathy again few months. So you have to right from preconceptional period to few months post delivery, you have to be constantly guiding the patient how to take care of her so that you can minimize the risk involved in cardiac diseases. So after listening to your presentation, I think the doubts and things are so clear that all of us would be very confidently will be managing our cardiac patients in pregnancy. Thank you so much, Dr. Sneha.
Thank you so much, Dr.
Over to you,
Sanchita
Dr.
and Dr. Rashmi Goyal. Thank you once again, and over to you, Niharika.
Thank you so much. And with this, we conclude our first session. Thank you to both our chairpersons and Sneha ma'am for this session. We will now move forward with our second session, which is on thyroid disorders during pregnancy. And we have with us Dr. Gorak, who will be speaking on it. I would like to invite the chairpersons for this session. Dr. Sadhna Jaiswal. Dr. Sadhna Jaiswal is a senior consultant, president of Greater Noida OBGYN Society, and she's with more than 20 years of practice and also a senior faculty at the Art of Living. She has been associated with a lot of organizations, Iron University, Indian Menopause Society, and also been associated with the GSVM Medical College, Kanpur. We welcome you here, ma'am. Our second chairperson for this session is Dr. Aradhana Singh, President of Noida OBGYN Society, Additional Director OBGYN Fortis Noida. She's also been the organizing secretary of the North Zone Yuva Foxy, has been actively working in the Sexual and Reproductive Health Committee of Society of Menstrual Disorders, executive member of Endocrinology Committee of Foxy, also been the member of Adolescent Committee of Foxy. We welcome you here, Dr. Aradhana, and I now invite Dr. Sadhna to introduce our.
Yeah. Thank you, Dr. Niharika. Thank you, Dr. Niharika. So I'll introduce Shella, no problem. Is she here?
I don't see her on the screen.
Okay, so I'll introduce.
Aradhana, you can take over, yeah.
Yeah. So first of all, thank you, organizing team, for making me the part of this wonderful webinar. So I would like to invite Dr. Gorak G. Mandrupkar. He is a consultant on reproductive medicine at the Center of Health Skills, Islampur, and he's the director of Angel IVF Clinic, Pune, postgraduate in the clinical research and medical legal systems. He's a member of Task Force National Policy on PPH, Government of India, and he invented the Gestosis, a score and affordable Indian innovation for screening the preeclampsia. And he has also drafted the guidelines on hypertension in pregnancy, FOXY, ICOG, Gestosis. He has got many books and publications and lectures to his credit. And so I welcome Dr. Gorak. He's going to be speaking on thyroid disorders in pregnancy, a very, very important topic. So welcome, Dr. Gorak. Hello.
Yes. Am I audible?
Yeah. Yeah,
And
yeah.
my
You are.
screen is visible as well.
No, sir.
Yes.
No.
Is it?
Yes, sir. Yes, sir.
Okay. So, good evening, all of you. And at onset, I thank for this kind introduction, as well as for inviting me in very prestigious Amogs Medical Disorder Committee with Agra, Noida, Greater Noida, and Mathura OBGY Societies Core Connect live webinar. Thank you very much for allowing me to share my views on thyroid disorders in pregnancy. Hello.
Yes, sir. We are able to. Yes, yes. Gaurav, we can.
Okay.
Yeah,
You
we
can
can
hear
hear
me,
you.
na? Right, right. Because I thought there was some disturbance. Right. So today I'm going to give brief review regarding the thyroid disorders. We all know that the somewhere some disturbance is coming.
Mehul, please check and unmute.
Yeah, exactly. Mehul, please mute everyone except Dr. Gaurav.
No, all are mute, but all are mute.
Okay, fine. So today we will discuss these thyroid disorders in detail, and mainly I will be discussing regarding the hypothyroidism and few concepts about the hyperthyroidism as well. To start with, a word for screening. It is a past that it was said that ideally the screening for thyroid disorders in pregnancy should be done on a case based. That means only in these 9 to 10 conditions we have to do the screening, and otherwise the screening not to be considered. But as I said, it is the past, because there were beautiful studies, especially the Vaidya et al., Horacek et al. They showed that when they compared the universal screening versus selective case-based screening for thyroid disorders, they found out that almost if we do the case-based screening, then we can miss 49% of the pregnant women with thyroid dysfunction. And that's why everybody recommended to do the universal screening. That means each and every pregnant woman must be screened for thyroid disorders. Yes, of course, the Indian guideline on the management of maternal thyroid disorders, let it be from FOXI or Indian Thyroid Association, or recently, as I showed, we at Amogs, we have drafted the recent guidelines for the standard practice recommendations for hypothyroidism, has also shown that all pregnant men should be screened at first antenatal visit by measuring TSH level. Now coming to the hypothyroidism in pregnancy, why it is important. We have a beautiful study, and Dr. Malhotra madam is here and she might be remembering that during her presidency itself, we had taken a very large study across the country, and we tried to find out the incidence of hypothyroidism in pregnancy. In Jammu, we could find almost 38 to 40%. In Telangana, it was 35 to 38%. In Maharashtra, it was 18 to 20%, so and so forth. So almost 12 to 40% is the incidence. It has definitely the geographical variations. Coming to the definitions, why we must know what is subclinical and what is overt, that is very important. These things must be very clear in our mind, because subclinical is nothing but it is just a biochemical evidence of thyroid hormone deficiency. And our thyroid hormones per se T3, T4 or FT4 will be normal. Only TSH will be little raised from 2.5 to 10. When we consider the case as a overt, here actually there is a symptomatic thyroid hormone deficiency where there will be low free T4 and definitely TSH will be more than 2.5 to 10. And any TSH which is more than 10, but still the free T4 is normal, it is to be treated like overt hypothyroidism. So these are the correct definitions. One must know, because again, this is of very much medico-legal significance. When we see what are the most common causes, definitely anything that is disturbing the thyroid gland in the form of infection. So chronic thyroiditis, autoimmune thyroiditis, subacute thyroiditis, radioactive therapy, thyroidectomy, or iodine deficiency. But here again, the last line I have kept, that iodine deficiency is the most common textbook cause. Why I have written so? Because in 2012 itself, WHO has declared India as an iodine sufficient state. So that means through the fortification of the foods and all, there is sufficient iodine we are getting, though maybe some of the pockets, they may be exceptional. There is a beautiful study in China, in Japan, and even we have done at our place, where we have found out that these sugarcane industry pollutants in the drinking water, they are mimicking the condition of Hashimoto disease. And that's why in our whole India, as well as in many of the Eastern and Western countries, we are getting so much of the hypothyroidism. In fact, you will be surprised that it was a traditional teaching that usually we do not get the hypothyroid patients on the bank of the sea or on the banks of the river. Why? Because most of the fish eating people are there and they get sufficient iodine. That's what even our park says, the textbook of preventive and social medicine. But in our study of why we have found out that maximum patients of the hypothyroidism we are finding on the banks of the river. And it is the reason, when we got into the details, it is the sugarcane industry pollutants in the drinking water. Again, there was a quarrel on what should be the levels of FT4, what should be the level of TSH. But do you know, these ITS guidelines or ATA guidelines, I will say first of all, ITS guidelines, it was just a meeting where it was discussed, and there are no proper randomized trials, or there are no level deciding studies, and this was just taken by the consensus opinion. Even initially, when it was accepted in the ATA, 77% of the members, they actually voted for these levels, and this is how it is accepted. So there is no scientific basis on that. And that's why recent ATA guidelines say, please use locally derived reference ranges from your specific pregnant population. And there is only one study from the AIIMS Delhi where professors, I do not remember, but maybe Dubey sir, he has given the Indian levels. But again in consensus meeting at POXI, Indian Thyroid Association, Indian Thyroid Society, it was accepted that, okay, let us come to some common line and accept these lines. So in first trimester, 0.1 to 2.5, in second, 0.2 to 3, and in third, 0.3 to 3 milli international unit per liter. These are the levels which are accepted by Indian guideline, again on consensus opinion. That we have to keep in mind, but in court of law, these will be accepted. Why we are so much worried? We are worried because untreated hypothyroidism, it increases the maternal risk for 3 P's. First P, pregnancy loss. Second P, preeclampsia. Third P, preterm labor. So it is very easy to remember and to tell the patient that why we are doing this TSH, why we are doing screening, why you have to take the treatment, because these 3 P's, they are waiting for you. And in overt cases, it is more than the subclinical cases. That's why we must know whether my patient is overt or subclinical. Because again, while treating, we have to start with accordingly about the dosages of L-thyroxine. Again, we have to tell the patient that if we do the inadequate treatment, low birth weight or FGR, and children with significantly lower intelligent quotients, they will be there. In India, there is iron deficiency anemia. We have hypoproteinemia. We have, and this hypothyroidism, if they go together hand in hand, there will be a problem of congenital cretinism, as we are getting in some of the northern districts of the Maharashtra. You all have heard Medghat. So there, this is a very common problem. And again, it is my sincere request to all of you. We have very much beautiful study on that. Iron deficiency, hypothyroidism, and hypercholesterolemia, they go by hand in hand. So in all your hypothyroid patients, please check the cholesterol level and you will be surprised. Oh, though my patient is thin, she has so much high lipids. So this all is interconnected. We have to be very careful on that. As usual, there was a debate whether to treat the subclinical hypothyroidism or not. But I have specifically marked it that it was a debate. Now it is very clear that even the subclinical hypothyroidism must be treated, though with low doses of thyroxine. What is the treatment? Oral levothyroxine. That's it. No other treatment. No desiccated products, nothing. If it is a case of overt hypothyroidism, we have to start with little higher doses of 50 to 75 microgram. While if it is a case of subclinical hypothyroidism, let us start with slow 25 to 50 microgram daily. And when patient is known case of hypothyroidism, and now she is pregnant, add 25 to it, depending upon the TSH level. This is how we have to keep it, very simple thing. When to prescribe this tablet? Preferably early in the morning. But what is the ideal recommendation? Ideal recommendation is after eating the thyroxine tablet, at least for 1 hour, nothing to be taken. That is the real advice. Otherwise, it won't get a proper absorption. It will be erratic absorption. When to check the TSH? After 4 to 6 weeks. When to reduce the dose? If the TSH have gone less than 0.1, when to increase the dose? If the TSH has gone high or still more than 3. How to do the increments and the decrements in the dosage? Very clear-cut guideline. It says that these must be done by 25 microgram. Sudden changes are not recommended at all. So example, we have started thyroxine 75. After 1 month, we have checked. TSH gone down below 0.1. So from today, I will tell my patient to make it 75 minus 25. That means 50 microgram. And I will not suddenly take it to 25 or 12.5. It is very clear-cut guideline. What is not to be given? Triiodothyronine, desiccated thyroid, or any other market preparations, inclusive of alternative therapies, they are not recommended at all. This is what very important is the postpartum management. Now here we have to be very careful. There are 3 types of patients. The first treatment, first patient, say for example, this is an overt hypothyroid patient, or a patient where initially we find out that TSH was more than 10, right? So what is the treatment? We have to continue the same dose as recommended. That's it. So after delivery, we should not reduce the dose. Second, subclinical hypothyroid patients, better to discontinue the treatment. We can discontinue the treatment. Third, patient was already hypothyroid. In pregnancy, we have increased the dose. So after delivery, we have to just minus that addition. And we have to continue her pre-pregnancy dose. Now, what is the recommendation? After 6 weeks, that means 42 days, check TSH and now read as non-pregnant level. And if it is high, start the dose. If it is normal, forget, because that was gestational hypothyroidism. So that is a clear concept. Is there any role of checking the TSH level of a baby? No, not at all in hypothyroid women. When maternal hypothyroidism there, usually these dosages are usually not required unless until the woman was on very high doses and she was a very severe overt hypothyroid woman. So this slide is very important. Screen with TSH, classify with pre-T4, monitor with TSH every 4 to 6 weeks, and treat with L-thyroxine. So all the thyroid-related hormones, they come here. So this is how we have to manage this hypothyroidism. Now, this is a concept that is when we were making TOGs, Madam Malhotra will remember that this was the terminology. At that time, I introduced when I was the chairperson of Medical Disorders of Pregnancy Committee, that there are cases of gestational hypothyroidism. So what are these cases? These are the cases, for example, the normothyroid patients having thyroid antibody positive, but still their TSH is normal. When they become pregnant, the demand increases, and now during pregnancy, they become hypothyroid. And as soon as the pregnancy is over, the demand has gone, and now they become normal. And all these patients, they require TSH monitoring during the pregnancy, and that's why we have done the recommendation that TSH should be monitored in each trimester. So just do the screening in first trimester and leave the patient. No, that is wrong. We have to do TSH, CBC, GCT, and gestosis score in each trimester. And then definitely, whatever cases we get, कि अरे सब तो अच्छा चल रहा था लेकिन ये ऐसे कैसे हो गया, such cases, they will be deleted. And we can get some answer after doing this proper testing. Now, second part of my talk is a hyperthyroidism in pregnancy. It is very less common. In that, 95% of the patients are of Graves' disease. More rarely, toxic multinodular goiter, adenoma, subacute thyroiditis, choriocarcinoma, or molar pregnancy. Definitions, again, yes, there is also subclinical hyperthyroidism and overt hyperthyroidism. When we call it as subclinical, normal FT4, but TSH has gone down. And when we call overt hyperthyroidism, high FT4, TSH has gone down. And why we have to classify, why we must know? Because it is a dictum that usually the subclinical hyperthyroid patients, we have to just wait and watch, don't treat them. Because some of the TSH low levels, they are accepted. That we have to keep in the mind. Now, what are the effects, of pregnancy Exacerbation may occur in the first trimester. Why? It is because of HCG production. Second, in puerperum. Why? Again, because there is a reversal or fall in the antibody levels if they are stimulatory antibodies. Can improvement or reduction in antithyroid dose occur? Yes, it can have. Why? Because during second and third trimester, there is a state of relative immunosuppression in pregnancy. And the levels of TSH receptor stimulating antibodies may fall. And in some of the cases, the ATD, that means antithyroid drugs, we have to reduce. But per se, pregnancy have no effect on Graves' ophthalmopathy. What are the effects of thyrotoxicosis on pregnancy? Preterm delivery, low birth weight, fetal thyrotoxicosis, but it is related to disease itself or treatment. Or in very rare cases, thyroid storm, that is a worst thing. Treatment, the goal is to maintain FT4 level in a high normal range using lowest possible dose. This line we have to keep in mind. We can keep little high normal level, but our dose should be lowest possible. Here, if TSH is not monitored, here free T4 is monitored. In hypothyroidism, we are monitoring TSH. And depending upon that, we are doing increments and decrements. Here, free T4. Why propyl thiuracil? Because it is traditionally preferred, safe, and last, it reduces the T4 to T3 conversion, and it works more quickly. And there was a concern in our mind regarding that methimazole, that it may lead to fetal aplasia cutis. But all recent studies, they have given that there is no problem. Though it is crossing placenta, methimazole can be used safely. It's very clear-cut guidelines. Dosages? Yes. Here, initially, we have to load the patient and do the maintenance. So when we are using carbimazole for initial 4 to 6 weeks, start with 15 to 40 milligram in divided dosage. And later on, 5 to 15 milligram in divided dosages. Same about PTU. Usually we start with 50 milligram TDS, and then later on, maybe 50 milligram BDOD or half of BDA, something. The relapse rates are high. Some women are managed with long-term antithyroid drugs. Subtotal thyroidectomy, this is again a theoretical discussion, very rare. The optimal timing of the surgery is second trimester. Usually such patients, they will go with endocrinologist, physician, and we have to refer and take their help. Beta blockers, yes, can be used for the symptomatic relief. But again, there is a word of caution. This may lead to, if though for use for a long time and in high dosages, may lead to FGR. So we have to weigh what is what. If she has so many symptomatology, we have to calm her, we have to tell her here the yoga and etc. All these things that definitely. Iodine 131, it is contraindicated. Regarding MTP recommendations, it is not clear that if already patient is taking, then what is what. But now, definitely, by discussing with the patient and putting the reason that continuation of the pregnancy may lead to the problem to the fetus or the mother, such cases, definitely we can help with MTP. I think last 1 or 2 slides. Here comes the umbilical blood sample. It should be considered. That is very important. All newborns of the mothers with Graves' disease should be evaluated for the thyroid dysfunction and treated if necessary. Here again, why I'm stressing it? Because there are 2 types of thyroid antibodies. Here, in case of hyperthyroid patients, one, either they are stimulatory or they are inhibitory. If they are stimulatory, the baby may lead to hyperthyroidism. If they are inhibitory, the baby may lead to hypothyroidism. And usually we do not do all these things, but it is better to check the fetus whether this is the baby is fetus is sorry, the neonate is or the delivered baby is hypo or hyperthyroid. And accordingly, we have to take the help of pediatrician and do it. This is a very beautiful last slide of Secretary of American Thyroid Society. We were in one meeting and he said that a thyroid disease in pregnancy is common, clinically important, and time sensitive. And our knowledge about it is rapidly changing. Because I remember when initially we prepared the guidelines of thyroid in 2014, there was something. When we were doing the TOGs, there was something. And now when we are talking in 22, 23, what I have uttered is something. Last thing, should we treat the thyroid antibody positive patients? The answer is no. Should we do the thyroid antibodies in pregnancy? The answer is no. Should we treat the hypothyroid or thyroid antibody positive patients in infertility? The answer is no. Then when should we treat the thyroid antibody positive patients? Only in cases of recurrent pregnancy loss, that too when they are present with other antibodies. Otherwise, there is no role. But one line of caution, when any patient comes to you for fertility management, there also do not use the non-pregnant levels of TSH, but use the first trimester levels of TSH. And we have to maintain the TSH less than 2.5, even in the cases of infertility. So thank you very much for patient listening, for kind introduction, for giving opportunity. I thank Dr. Sneha Bhuyar Madam for calling me, and let us join hands together for more thyroid studies. Those who are interested, please join us. This is a very simple email ID, mango.ivf@rediffmail.com. And definitely we can conduct so many thyroid studies across the country. Thank you very much.
Thank you. Thank you, Dr. Kumar.
Thank you, Dr. Sneha, for giving me this opportunity to be a part of this special webinar. And thank you, Dr. Gaurav, for a wonderful, a very lucid talk. And especially, I was really going to say that every now and then the guidelines are changing. What should be the level of thyroid in pregnancy, hypo and hyper, and you have very clearly told us. And in the last, when you said, really, very oftenly we are advising thyroid antibodies, and we are treating the patient also. So now we need to know that only in cases of RPL, we need to treat this patient. Wonderful talk, Dr. Gaurav. Thank you so much. It was very, very nice.
Excellent talk, Dr. Gorak. Thank you. Thank you, Sneha. Thank you.
Thank you so much, Dr. Gorak. It was a really informative talk. Thank you to the chairpersons for this session. And to move ahead for the last session, which is the very interesting quiz session, I would like to now invite Dr. Shaila Jamal. She'll be the quiz master and will be conducting the next session. Dr. Shaila Jamal is an associate professor from Bareilly. She is a menstrual health specialist and a medical activist. She has done tremendous work on menstrual hygiene and is now the founder and president of the Society of Menstrual Disorders and Hygiene Management, and a very active member of the Young Talent Committee of FOXY. So over to you, Shaila, for the next session.
Thank you so much, Dr. Niharika. And kindly allow me to share my screen. So I hope the teams have joined. I was going through the names. So Niharika, please tell me this slide is visible?
Yes, yes.
Okay. So thank you, and thank you so much to Sneha ma'am for giving me this opportunity. Although this might not be the best of our picture, but certainly it's most special and most valuable, as you
Shella,
can
it's
see
not
both of
moving.
us.
Yes,
Uh,
Shella. Yes, your slides are not moving. You can make it full screen. Just click once again on the slide.
sure.
Wonderful
Is
talk
there
by
any?
Dr. Gorak, and definitely I'm sure that most of the doubts have been clarified. But I think Gorak, this quiz is also very interesting, and if at all if there are any questions, I think we would be very happy to solve them. So I request you to stay back if at all you are free for some time. So we have four teams. Shaila, you can go ahead.
My screen is visible now.
No.
No, my dear, you have to share your screen. It's not shared. No.
There is screen share, and now Ab,
Yes, yes, can see now.
and we are moving the slides. Are they visible?
Yes, now.
Okay, so I've already thanked Sneha ma'am. Need to thank her once more. This was the picture clicked in AICUG Kolkata. Met her, learned a lot from her. Always, today, tomorrow, and forever. And best wishes, Sneha ma'am, for all your future endeavors. And we are sure you will not forget us. Thank you. So,
Thank you, my pleasure.
thank you. Thank you, ma'am. And for the quiz today, it was a brilliant idea again by Sneha ma'am only. She only ignited this light. And we are so privileged to have Dr. Sushma Gupta ma'am, President of Agra Society, and Dr. Rakhi Singh ma'am, Chairperson, Endocrinology Committee of FOXY. And we have seen her humongous work in the field of endocrinology, and much is related to medical disorders in pregnancy also. So it's my proud privilege, and I'm quite excited to introduce the quiz participants today. Dr. Deepika Negi from Noida, Dr. Sonal Agarwal from Mathura, Dr. Purva Asana from Greater Noida, Dr. Yogen Chandel from Mathura, and Dr. Apurva Patel and Ishu Grewal from Agra Society. So, because the participants, the numbers are slightly irregular, but I believe कि एक नारी सब पर भारी. तो जो teams अकेले अकेले हैं, don't sweat it out. We are all here to learn and enjoy this entire phenomena of quiz. So, if judges allow me, I would like to tell the rules, ma'am, because I'm not able to see the screen anything. Rakhi ma'am and Sushma ma'am.
Hi. Hello.
Yes,
Sushma ma'am.
Dr. Sushma, we can hear you. Please go.
Yeah. So it's a pleasure being here. It's a
So, ma'am,
pleasure being here with you. And I enjoyed the sessions today very well. The started and hard is both were important. So learned a lot. And Dr. Sharla, I would like to let the participants of the quiz so that they answer well and they all of them win. And we learn something. Thank you. Hello.
Thank you so much, ma'am. Thank you.
Yes, Dr. Shaila, another thing, I may have to leave this session. So, Dr. Poonam, if I am not there, Dr. Poonam Yadav would take my place. Okay? Okay.
So, thank you, esteemed judges, for allowing the session to start. So, before that, I would like to spell out the rules. There will be 3 rounds. Each round has different pattern of questions. There is no negative marking, but no pass is allowed either. And we have tried to take references from standard text. Still, in case of any dispute, at present time, judges' version will be taken as final. So thank you, judges, because your role is very much important. And we need to keep time as well. And during the entire quiz exercise, you just chill down, and we will be asking questions. They are very easy. We all are there to enjoy. And yes, I'll be telling that. So my beautiful timekeeper, Dr. Nandini, she is reminding me कि मुझे और rules बताने, so I'm going to tell those ones also. So in round 1, each team has to answer 4 questions. Second thing is, each question will be carrying 5 marks. So each team can score maximum of 20 and minimum 0. And we wish none does that. There is no negative and no pass is allowed again. So team 1, I have arbitrarily, this also Nandini has done for me. So team 1, kindly note, Dr. Deepika Negi from Noida is team 1. So Dr. Deepika, you need to tell me yes or hi.
I think, Shaila, let us ask them to put on their video.
Yes, and
We
please put
can't
on
see
their
them actually. Are they here online first?
Dr. Deepika? So anyone from Noida Society? So Dr. Deepika Negi, are you here? Okay, team two.
Doctor, I can see Dr. Apurva Asthana.
Yes, ma'am.
And Ishu Grebal, yes.
Dr. Ishu and Dr. Apurva together. Dr. Apurva Asthana from Greater Noida. Dr. Sonal and Dr. Chandel as one team. So we need to confirm Dr. Deepika Negi's presence. क्या मैंने ये सुना कि मैं गूगल चला लूंगी? नहीं, log in from this one. Dr. Deepika Negi, are you here? म्यूट कर दो यहाँ से. नहीं, एक log out करो. Well, I'll be able to see.
Do we have Dr. Yogendra also here?
No. So any volunteers for today's quiz?
How many teams do we have? I mean, who are the teammates who are present? That is how we can go, Shaila.
Yes, yes. So Dr. Apurva is present. Both the Apurvas are present. Dr. Ishu is present. Dr. Sonal has joined.
Yes, Dr. Vartika. Dr. Vartika.
घर में यहीं पे पीछे डाल दी बेटा, वो पहले उसको लिया फिर उसके बाद डाल दी, कहते रहे.
Vartika ma'am.
Okay, I think you can define the teams, Shaila, and you can start.
So Dr. Apurva Asthana is team 1. Second, Dr. Apurva is team 2. Dr. Ishu Grewal is team 3. And anyone from Mathura? Sonal, Dr. Sonal, Dr. Chandel? So fourth question will go to audience. Fourth go out. So we will not include fourth question in our marking scenario. So to Dr. Apurva Asthana. We need to see you on screen, Apurva. Yes, please unmute yourself. So your question is, and you'll be given 30 seconds per question. So do I see sweat? Not yet. What is the maximum increase in plasma volume during pregnancy? Thank you.
50%.
Please note the answer, 50%. Second question for you is, what is the cutoff for anemia in pregnancy as per CDC guidelines?
I mean, which trimester, overall or trimester wise?
Yes, tell us trimester wise.
11 in first, 10.5 in second and third, and 10 in the postpartum.
Okay. So we have noted your answer. third question for you is, what is the dose of iron recommended by WHO for prophylaxis and treatment of anemia in
60,
pregnancy?
60 mg. 60 mg.
Both for prophylaxis and treatment?
Prophylaxis 50, treatment 100.
Write it down. Okay. What is 6 by 6 by 6 strategy adopted by Ministry of Health and Family Welfare for eradicating anemia? So, okay, time is up, Apurva. So you've answered 3 questions, and we will be coming for scores later on. Nicely attempted, although. So, second, Dr. Apurva is ready.
Yes,
I need to see your face, please.
Dr. Rakhi, please keep the score and the time as well. Shehla, how much time to
30
answer?
seconds. 30 seconds. Yeah. So, Apurva Patel, I can see a young, bubbly gynecologist, and all the best to you. So, your question on screen now. What is the maximum increase in cardiac output?
We're going to give the answers in the end, or how it would be?
In the end, Rakhi, because teams are not proper. Apurva, we are waiting for your answer. Maximum increase in cardiac output during pregnancy.
10 to 15%.
Sorry?
10 to 15%.
Write it down, please. 10 to 15%. What is the commonest acquired heart disease in pregnancy?
Rheumatic heart disease.
Rheumatic heart disease. Third question for you is, what is CAR-PREG2 score?
Right. Next question.
Next question. What are the cardiac conditions for absolute indications for termination of pregnancy?
Aortic dissection.
You were not there for the talk.
NYH grade 3, grade 4.
NYH class 4, 3. Then?
You were not listening to the talk, Apurva.
Time is also up. ये तो सारा disclosed वो था. Sneha ma'am just told every answer in this topic. So we will tell the answers in the end of the first round. So Apurva, nicely attempted. I wish you luck. So third question is for Dr. Ishu. Are you here? We need to see you on screen.
Yes, ma'am.
Okay. So Ishu, घबराने की जरूरत नहीं है, बहुत आसान वाला है अभी. Ready?
Yes, ma'am.
What is the maximum increase in GFR during pregnancy? Glomerular filtration rate. The time is up. Second question for you is, what is the definition of asymptomatic bacterial?
When there is presence and bacteria, but no pustules in the symptoms are absent, but presence of and multiplication of bacteria in urine. Symptoms are absent, but colony per ml of presence of and multiplication of bacteria in the urine.
Okay. So am I the only one who is not able to hear her?
Is present.
Okay, ठीक है. So your third question is issue. What are the signs, clinical signs of pyelonephritis?
Hello.
Yes,
Ma'am, I
Ishu.
cannot hear.
What are the clinical signs of
Ma'am,
pyelonephritis?
I
There's
cannot hear you.
slide तो है बाबा सामने, क्वेश्चन है.
I cannot hear you.
Issue.
I'm paying it and
So fever, nausea, then तुमने enter किया इसमें login. So I'm yes, Ishu, you need to answer. Although time has passed for this. Please unmute yourself.
Yeah. I can see Dr. Yogendra Singh also, I think from Mathura. Yeah.
Yes.
Yes, ma'am. Dr.
Hello.
Chandel has joined, ma'am.
So that is the last question for you. What is rifle criteria issue?
Full criteria.
Rifle criteria and the question is for issue. Rest others, please mute yourselves.
Pass, ma'am, pass.
Risk, injury, and failure. Hello. Hello.
Yes, yes, tell us. So, ma'am, time has
Hello.
passed. We take it as the answer not attempted. Okay. So, Dr. Chandel, are you ready? We need to see you on screen, please. And Dr. Ishu and Dr. Apurva,
Just
can
a
you
moment.
give me network? Dr. Chandel, are you ready for the next round?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So please switch on your video, please.
Okay, okay.
So welcome to the quiz, and you are the fourth team also from Mathura. You are representing.
Yes, ma'am.
So all the best. So
Thank
your
you.
question is, what is the RDA of iodine during pregnancy as recommended by WHO? Time.
Wow, it's one no, it's 1 microgram per something, ma'am. I don't really remember the
1 microgram liquid. And the time is over also. So your question second is,
right.
When does fetal thyroid gland become functional?
Somewhere around 9 to 10 weeks, if I'm not wrong.
Okay, 9 to 10 weeks is your answer.
Yes.
Then with which drug is aplasia cutis of the neonate associated?
Aplasia cutis. Aplasia cutis. Thalidomide?
Okay, right, thalidomide is answer. So fourth and last question for you, what are the diagnostic criteria of thyroid storm in pregnancy?
Maternal tachycardia.
Okay.
And I remember the other one is
Ishu, please mute yourself.
tachypnea.
Oh, time is over. Dr. Chandra. So, Rakhi ma'am and Sushma ma'am, we have noted down the answers also, and we will be assisting you in making the scores also. So, Dr. Nandini is doing that while we discuss the answers for the above questions. So, Dr. Apurva Asthana, the first question was asked to you. So, let us hear What is the maximum increase in plasma volume during pregnancy? Answer is 40 to 50%, and you told it correctly, 50%. Second question was, what is the cutoff for anemia in pregnancy? As per CTC guidelines, it is less than 11 gram percent in first and third trimester both, and less than 10.5 gram percent in second trimester. So Rakhi ma'am, she answered a bit differently. So would you like to give full marks for this question to Apurva? Sneha ma'am is saying yes already.
She answered 11 grams in the first trimester, 10.5, and Purparium she said 10.
I think we should.
Yes.
So Apurva, chocolate. Okay. So third was your 6 by 6 by 6 strategy. This has been adopted by Ministry of Health and Family Welfare. 6 as 6 beneficiaries, 6 as 6 intervention, and 6 as 6 institutional mechanisms, which include a lot of activities, including Anemia Mukt Bharat that we are doing today. So one of them is prophylactic iron folic acid supplementation. Second is deworming, then intensified year-round behavioral change communication campaign, testing of anemia using digital methods and point-of-care treatment, mandatory provision of iron folic acid fortified foods in public health programs, and addressing non-nutritional causes of anemia in endemic pockets. So this was the answer not attempted by you. During pregnancy, WHO has recommended 60 milligram of elemental iron and 400 microgram of folic acid, and treatment just double the dose. So we give 1 OD as prophylaxis and 1 BD as treatment. We are following Ministry of Health and Family Welfare guidelines, which says 100 milligram of elemental iron and 500 microgram of folic acids, right? And we double the dose when we treat it. So treatment of prophylaxis में सिर्फ doubling का फर्क है, बाकी same ही. So Rakhi ma'am, she told 60 milligram and 100 milligram. So would you like to give full marks?
Yes.
Okay. So a double chocolate for Rakhi ma'am, Apurva की तरफ से. So thank you so much. That makes 15 as her score. So second was for Dr. Apurva Patel. So maximum increase in cardiac output during pregnancy is 40 to 50%, and she told 10%, 10 to 15%. So Sneha ma'am, I think that is the grossly wrong answer. So she said rheumatic heart disease, which is correct, and we still see it. More than 80% is mitral stenosis still. So that was one correct answer. Third is Carpreg 2 risk predictor, which she did not attempt. So that again calls for 0. And fourth were absolute 4 reasons for termination of pregnancy: NYHA class 3-4, aortic dissection, pulmonary hypertension, Marfan syndrome with aortic involvement, and uncorrected Fallott's tetralogy, mitral stenosis with atrial fibrillation. And I think Sneha ma'am आपने 3 बार ये वाली slide बताई थी, like you told thrice. So issue for fourth answer, ma'am, she said 3 indications. So I think we can give 5 marks for that.
Yeah.
Okay. So she scores 10 with this strategy. This is for Apurva Patel. So third was asked to issue, and the first question asked was maximum increase in GFR during pregnancy, which was not attempted by her. So you get a 0 for that, and the answer is 50%. And the definition of asymptomatic bacteriuria, which is very important, and for PGs especially, bacterial count of same species. That is one thing. 10 to the power 4 colony, 5 colony forming units in mid-stream urine cleat catch specimen on 2 separate occasions without symptoms of clinical infection. So she told 2 things, I think, कि symptoms नहीं है और same species, I think she told. So judges sweet लग रहे हैं मुझे आज बहुत.
I think what I guess is
I think bacteriuria, the definition has to be correct.
Correct, has
that
to
is
be
important. That is very important.
Because she said asymptomatic bacterial, very word-wise meaning. She what just indicated. The colony count is very important in this, so I think we should not give this.
Okay. And the next
now
question.
She'll never forget in her life.
So next
that
question
is
was
10 to the power of 5.
So signs and symptoms of pyelonephritis: acute loin pain radiating to groin, costovertebral angle tenderness, urgency, frequency, hematuria, fever with chills, nausea, vomiting. They are very vague symptoms, and they cannot be specific for pyelonephritis in pregnancy. And pyelonephritis is a deadly killer in pregnancy. So we just cannot afford to miss this costovertebral angle tenderness and loin pain, right? So ma'am, she told nausea and pain, both two very unspecific, although we lost her voice also in between. So judges, no. Okay.
I
And the
think
last
fever with chills and the pain from loin to groin, the radiating pain, I think very classical.
yes, ma'am. So the last question asked to her was rifle, which is risk, injury, failure, loss, and end stage kidney disease. So even this was not attempted by issue. So she gets a score of 0, and but you know there are 2 more rounds. So team 4 asked her RD of iodine in pregnancy is 100 to 200 microgram per day, and if you have to quote one, it is 150 microgram per day, which we are also following. So this was a wrong answer.
Right.
Second question was fetal thyroid glands become functionally active after 12 weeks. You said it 9 to 10 weeks. Balki 14 to 16 is the full functional activity of fetal thyroid gland. Methimazole is a drug. We all rectify it for our NEET PG, and abhi PGs ko padha ke bhi ge rat lo yaad. We don't give it in first trimester. So that was again a wrong answer. And the signs and symptoms of thyroid storm in pregnancy are given: hyperpyrexia, tachycardia, congestive cardiac failure, neuropsychiatric symptoms, nausea and vomiting, and lab TSH value of less than 0.1. So I think you just said about tachycardia.
Tachycardia.
है ना? तो Dr. Chandel, sorry,
0.
but there are more rounds.
Right, ma'am. Thank you.
So with that, Dr. Apurva Asthana is leading with 15 points, and another cute Dr. Apurva Patel with 10 points, and Dr. Chandel and Dr. Ishu have yet to open their accounts. So all the best. We are heading to round 2. Round 2 is clinical case discussion. Each case has 4 questions, 5 marks each. Again, no negative and no pass is allowed. So team 1, again, Dr. Apurva Asthana, we need to see you on screen. So here is the lady or girl, I'll tell her. So Apurva, your patient is a primey with 24 weeks of gestation. Her blood pressure is 150 by 100 millimeter of mercury, and her urine dipstick shows albumin to be +1. No other complaints were there. Urine output was also normal, and her first trimester BP records were also absolutely normal. So Apurva, what is the diagnosis of this patient as per this clinical scenario?
24 weeks.
Yes.
PIH.
PIH. Okay. Kindly note. What treatment will you start now?
Antihypertensive.
Which one?
Labetalol.
Dose?
100 mg twice daily.
Okay. Name 4 important investigations you will do to assess disease severity.
CBC with platelet count, LFT, KFT. Urine albumin has been done. And serum electrolytes. Hemolysis elevated. That's it.
Okay. Name 2 complications of this condition, Apurva.
Eclampsia. Eclampsia. And kidney injury. Acute kidney injury.
Okay. So, Purva, we will be discussing answers here because our teams are here. So now the term PIH is out. It is hypertensive disorders of pregnancy. Yes. And your patient, since she developed hypertension after probably 20 weeks because her first trimester BP records were normal, she falls into the category of pre-eclampsia. She had no symptoms. Urine output was also normal. Urine albumin was also 1+. So she's a case of non-severe variety of pre-eclampsia. Fine. Second is you answered it correctly. Labetalol 100 to 200 milligram BD. 4 important investigations. You answered CBC with platelet count, and we'll take that as correct answer. KFT, and then did she say LFT?
LSP.
Coagulation profile is important. Another important thing is ultrasound for fetal well-being assessment also. So serum electrolytes, see, there is no impairment of electrolytes in this condition, especially non-severe variety. So that becomes a secondary investigation. We don't do serum electrolyte to quantify the disease severity in preeclampsia. Fine. So next answer, complication eclampsia was right. I would have been happy if you have told you would have told HELP syndrome, because we are doing the entire exercise to rule out HELP syndrome here. So judges, the esteemed judges, she told PIH. Again, classification was not done. So do we take it as correct answer with full marks?
Yes.
Yes.
So classification was not there.
So labetalol, she answered correctly. Most of the investigations were also told by her, and complication of eclampsia and acute kidney injury.
Yeah, I think just one note I would say here, that hypertension, HDP, you label it as HDP gestosis. Nowadays, no more PIH, but definitely assessing the severity. So it is to be classified only as severe and non-severe, and not otherwise. So I think that's the only note from my side. Otherwise, you can consider. Thank you.
So 20 marks to Dr. Apurva Asthana for this question. Congratulations. So Dr. Patel, we are coming to you. Dr. Apurva, I need to see you on screen with good network, please. Dr. Apurva Patel, please switch on your video also. Yeah. So are you ready?
Yes.
A fourth gravida, para 1, living issue none, and 2 abortions, visits your clinic at 15 weeks, 4 days. She is giving you history of curdy white discharge per vaginum. There is increased thirst history since last 1 month. She delivered a baby with multiple malformation at 32 weeks in previous pregnancy, which was obviously a stillbirth. So Apurva, what is the provisional diagnosis as per clinical scenario in your case?
Diabetes mellitus.
Okay, so I have noted down. What is the test that will be done to confirm the diagnosis? Apurva?
Yes, ma'am.
What will
I
be the
cannot
test
see
that
you.
will be done to confirm the diagnosis in this case?
I cannot see you.
Sorry?
It is not visible.
Screen is not visible. Screen to visible hai. I have logged in with 4 devices for this reason. It is visible.
Yeah, screen is visible. What is the test that would be done to confirm the diagnosis? How will you confirm the diagnosis?
Ma'am, DIPSI criteria for screening and then OGTT.
So OGTT is different and DIPSI is different. Okay. So we have written your answer. What are the values of this test?
Ma'am, more than 1.
Apurva, we are not able to hear you.
What are the cutoff values for DIPSI or for OGTT, whichever you want to tell?
More than 140 in intolerant glucose intolerance and more than 200 over diabetes.
Okay. So last question for you. Name 2 perinatal complications of this condition.
2 perinatal complications, ventricular septal defect.
Sorry?
Genesis, ventricular septal defect.
Ventricular septal defect and sacral agenesis. Perinatal complications पूछे थे Dr. Patel. So here are the answers. The answer is hyperglycemia in pregnancy. So that can be of two types, diabetes or gestational diabetes mellitus as per the criteria. You were right in DIPSI, that is OGTT with 75 gram glucose. That is a single step screening as well as diagnostic test, and we are endorsing it and following it. And as per the criteria, if the values are less than 120 gram per deciliter, it is normal. 120 to 139, it is gestational glucose intolerance or impaired glucose intolerance. 140 to 199, it is gestational diabetes mellitus, and more than 200, you were right, it is over diabetes mellitus. So perinatal complications occur during birth. So what you told were congenital malformations or fetal complication or fetal affections. So the more important complications which we see in hyperglycemic pregnancy is malpresentation and associated cord prolapse. I mean, I've just given an option, and we would have been happy if you have told us about shoulder dystocia. So Rakhi ma'am, initial 3 questions were right, but last question ke liye what is your take?
No, it was perinatal complications which we asked, and she mistook it to neonatal complications.
Okay. So for this, it is not given. So she scores 15 marks in this round. So Dr. Ishu, I hope your net is good. Please switch on your video also.
I think she's having net issue. Let her video be off only. Probably when she's owning the video, her net is going off further.
ठीक है, switch off कर लो video. बस आंसर जोर से बता दें. ठीक है इशू?
Yes, ma'am. Yes, ma'am.
So your question is a primary gravida with 31 weeks coming to you with complaint of itching all over the body, including palms and soles. However, there were no rashes, but only scratch marks over abdomen. She had one LFT done 2 days back, in which AST was 145 and ALT was 186. Bilirubin was normal in this liver function test report. So what is the provisional diagnosis of this case?
Ma'am, cholestasis in pregnancy.
Okay. What is the next test to be done to confirm the diagnosis?
Is normal.
Sorry?
Bile salts.
Bile salts. Okay. When will you deliver this patient according to the level of bile salts?
Ma'am, 38 weeks.
Okay. That is your absolute answer? What are the fetal complications in this case? Fetal.
Ma'am, sudden IUD, premature intrauterine growth retardation, preterm delivery.
Okay. What is the cause of this sudden intrauterine fetal death?
Okay, ma'am. So answer cholestasis of pregnancy, intrahepatic cholestasis of pregnancy. Next test then is serum bile acids and not salts. So bile salt तो नहीं कराते हैं?
Yes, ma'am. Bile acids. Yes, ma'am.
हाँ वो राखी मैम बताएंगी yes है या no है.
Yes,
So now the classification is like, if the bile acid level is less than 19 micromole per liter, it is known as gestational pruritus. Mild ICP with bile acid level of 19 to 39, moderate ICP with bile acid level of 40 to 99, and severe ICP when there is itching and raised peak bile acid concentration of more than or equal to 100 micromole per liter. And this is a very important investigation, because based on this and fetal assessment, we make our decisions to deliver. So it is given on your screen. In mild, we plan birth by 40 weeks, and we assume कि और कुछ गड़बड़ नहीं है. In moderate, we plan birth between 38 to 39 weeks, but in severe ICP, you are still delivering at 35 to 36 weeks because of increased risk of sudden intrauterine fetal demise. एंड स्नेहा मैम का जवाब कौन देगा कि क्यों हो जाता है सडन आईयूडी? एनीवन, अपूर्वा और इशू, बिकॉज आई नो यू आर पीजीज एंड यू आर सपोज्ड टू नो दैट.
What is that event that leads to fetal death?
Deposition of bile salts in
Where?
the heart. Is a deposition of the bile salts in the heart, ma'am, where the cardiac activities goes down.
So okay, so tell me the scores now. Rakhi ma'am, bile acid bile salt वाला छोड़ दिया जाए या?
I think we should leave it.
So she scores 15 in this round, and kudos to you, Dr. Ishu. And we're coming to you, Dr. Yogesh. So your question, sorry, we did not answer this, but she told it right. Meconium staining is stillbirth and preterm delivery. So Dr. Yogesh, we need to see you on screen because your network was all right.
Yes.
Okay. So a 21-year second gravida with previous abortion comes to you at 11 weeks for routines. She gives history of epilepsy since childhood and has been taking some anticonvulsants in past 8 years. She does not know which drug she is taking. And last seizure episode was 4 months back. So your question is, what is the safest anti-epileptic drug that is recommended to be used during pregnancy? Time.
Levetiracetam.
So that is levetiracetam. So we'll take write this as an answer. Second is, what test of fetal well-being will you offer to this patient who was not knowing what drug she is on and what not at 11 weeks?
11 weeks, I can offer her a NT-NB scan plus double marker.
Okay. And any other thing? Further?
CVS can be done. It's a NIPT can also be there if there is
ठीक है,
a
वो
real
पहला
doubt.
वाला आंसर आपका ले लिया है. और बाकी और आगे फर्दर प्रेगनेंसी में और कोई टेस्ट ऑफ फीटल असेसमेंट?
Or test, ma'am, we'll go for quad markers and amniocentesis if there is a great history about it, and until unless there's something in the syndromes.
Okay, ठीक है. So what are the fetal complications you expect in this pregnancy?
All antipsychotic drug, the general tendency of them is fetal congenital anomalies. They tend to see structural anomalies is what we are worried about. How much depressing they are to the hypoxic conditions. So placental insufficiency can be one of the reasons. Can be the cause. What I'm expecting, whatever happens is because of the placental insufficiency.
Okay, we've taken 2 of your answers. And name the fetal condition associated with phenytoin used during pregnancy.
Phenytoin toxicity, that is known as fetal.
उसका नाम क्या है?
अरे मैं भूल गया. Phenytoin syndrome. I'm not able to recollect. Not able to recollect.
So I hope after this we will be able to remember forever. So judges, kind note the safest anti-epileptic drug, which is professed by all the colleges across the globe, is lamotrigine. We can supplement it with carbamazepine and levetiracetam. Both are plus. The advantage of carbamazepine is also that it is not an enzyme inducer. So he answered levetiracetam, which is not that safe, but still we can give. So we will ask judges for your answer. Second is first trimester screening, as you rightly said, especially we'll look for fetal head, as with phenytoin use, folic acid suppression and deficiency seen and neural tube defects are very common. So we will offer her TIFA because of the same reason that she is at high risk of neural tube defects. If we have done first trimester screening, there is no role of quadruple marking in these patients or in any patient per se. Fetal malformation, you rightly said, fetal growth restriction, oligohydramnios, stillbirth, the incidence is increasing by 2 folds. And fetal hydantoin syndrome.
Hydantoin syndrome.
Yes, Dilentin syndrome. Dilentin says है. We were learning it in our PG days. So it includes cleft lip, cleft palate, congenital heart disease, slowed down growth, and mental deficiency or retardation. So Rakhi ma'am, for the first answer, do we give marks for levetiracetam? Yes, Sneha ma'am.
Yeah.
Okay. Safest पूछा था वैसे safe नहीं but still because judges decision will be final. दूसरा आंसर इन्होंने दिया था, आई थिंक ये ठीक है. फर्स्ट ट्राइमेस्टर स्क्रीनिंग ही टोल्ड राइट along with quadruple. So okay, मैं बता देता हूँ congenital malformation. Complication में the most important thing was pointed out by him, that is the congenital fetal anomalies, and this was not answered by him. So the marks scored by Dr. Chandel is again 15, and we clap for everyone. So, Sneha ma'am, I would like to ask you, shall I go for third round or wrap it up over here? If the time allows, we can go.
Yeah, I think, Rakhi, what do you say? I think done.
इसमें बहुत time लगेगा भी, बहुत छोटा round है वो.
छोटा सा है. Okay, can go.
Okay. So this time we have reversed the team sequence. So Dr. Chandel, it's your turn first.
Right, ma'am.
Okay. So scores, Dr. Nandini Chandel. So here is an X-ray picture. Identify the clinical condition associated with this.
Gas under diaphragm.
अरे जहाँ वो मार्क बना हुआ है वो बता दीजिए सर.
एक मिनट. Hilar lymphadenopathy.
Okay. Which drug in ATT causes orange discoloration of urine?
Rifampicin.
Good. So the answer is pulmonary tuberculosis. So hilar lymphadenopathy is a feature of pulmonary tuberculosis.
Tuberculosis.
So we take both these answers as correct in your case. Second is for Dr. Ishu. Ishu, are you here?
Yes, ma'am.
So your screen shows microcephaly, patent ductus arteriosus, and probably a cataract, right? So identify the condition.
Ma'am, congenital rubella syndrome.
Okay. What are the ultrasound features of fetal affection in this condition?
Ultrasound. IUGR.
IUGR, right. So time is over. Time is over, issue. So you were right in telling us that it is congenital rubella syndrome, and ultrasound features are very many. तुम दो चार ऐसे ही बोल देते ना तो वो वहाँ फिट नहीं बैठ जाती. So IUGR तो वो तो हम हर जगह चिपकाते हैं जब हम PGs होते हैं ना, हर आंसर में.
Symptoms are there on the screen itself.
और microcephaly, periventricular calcification, ventriculomegaly बड़े common होते हैं when we are reading about viral infections in pregnancy, right? So Rakhi ma'am, for this answer, because she just told about FGR, nothing more.
Yeah. Yeah.
So marks दें या नहीं दें?
Half mark.
So 5 will give to some. Okay. So team 2, that is Dr. Apurva Patel. Yes, Miss Patel, you see this slide? You see these two things? Identify the pathological condition shown in this peripheral smear slide.
Malaria.
What is the dosage schedule of chloroquine in pregnancy? Your time is over, Apurva. Malaria नहीं आ रहा pregnancy में आगरा में. So answer is you were right, malaria falciparum. बहुत classical picture है. You could have told us falciparum as well. So the dose is 600 milligram base, that is 500 milligram of the drug per oral, followed by 300 milligram base 6 to 8 hours later, then 300 milligram base daily for next 2 days. बहुत easy है, बना हुआ आता है पैकेट में. And to prevent relapse during pregnancy, 300 milligram to be taken weekly until delivery is also the latest recommendation. So yes, ma'am, first question was answered by her, second was not attempted. So 5 feet. So Dr. Apurva Asthana, for you, you see a picture, VCTC, Voluntary Counseling and Testing Centers, fine? For which condition are these centers dedicated for?
HIV.
Okay. What is opt-out approach in this?
If the patient doesn't want to get tested, the patient can opt out of it. Further counseling needs to be done and a repeat test needs to be offered.
So very rightly said, for HIV in pregnancy, opt-out is recommended, where we need to tell the patients that tests will be performed and she may elect or decline or defer testing. So you were very right in telling us in repeat offerance of the treatment also. So I think both the answers were correct. So Rakhi ma'am and Sneha ma'am, so we are coming with the scores. Give us just 2 minutes. कितना है? ये total है ना? Okay. I'll send the pictures clicked for the scoring that has been done along with answers also in case there is any doubt or dispute. So, मैं भेजूं? I would like the judges or Sneha ma'am to announce the winners. So how should I do that?
Dr. Rakhi will do that.
No, Sneha, you do it. I think Sneha should be doing it.
Dr. Rakhi and Dr. Sushma, they are the judges. They will announce the result and I'll be just there to conclude.
Okay. So Rakhi ma'am, I'm sending the result to your mobile. Fine. हो गया हाँ नाम लिखो ये हैंग करके देखना more than everyone, I'm waiting for the results.
That's the toughest job what you've given to me, Sheila. So I'll start with the third, the 3-2-1 or 1-2-3 or 4-3-2-1.
जैसे आप चाहें मैम.
Dr. Chandel is on second runner-up with 25 points. Dr. Apurva Patel, congratulations. You are the second runner-up with 30 points.
Thank you, ma'am. Thank you so much.
Congratulations. And Apurva Asthana is the first prize goes to her, which is 45.
Thank you.
Congratulations to all four of you.
Thank you, sir.
Congratulations, all of you.
Chandel. Issue is also very close to Chandel. And all four of them did very well. Congratulations for all four of you.
Thank you. Thank you.
Thank you, ma'am.
Sneha ma'am, your words, please.
Yeah, so hearty congratulations, all the participants. I would say you have really made it very interesting. And Shehla, आपका क्या कहना? What a master you are. You know, you are the master of the quiz. So I always prefer you to be the quiz master, and definitely the teacher within you gets an opportunity to teach simultaneously. So we are very happy for this round. It is really very interesting and something different, innovative. So I really enjoy having these sessions with you. So thank you so much. Once again, I would thank all the societies, Agra, Noida, Greater Noida, and Mathura. I have already thanked all the presidents and secretaries of all the societies. And I once again thank our guest of honor for today, Madam Jaideep Malhotra, Dr. Sunita Tandulwadkar, and Dr. Milin Shah, Dr. Gorakh Mandrukar, the speaker, and all the participants of quiz who are here, Dr. Chandel, Dr. Apurva Astana, and Dr. Apurva Patel, and Dr. Ishu. So, Ishu Grewal. So, all of them, hearty congratulations. I thank all my conveners, Dr. Raki Singh and Dr. Vartika, for making it very fruitfully to happen. And thank you so much, my wonderful coordinators, sweet friends, little cute friends who are always there with me, Dr. Niharika and Dr. Shaila. So thank you so much, and over to you, Shaila and Niharika.
Thank you so much, ma'am, and congratulations
Sorry.
to all the winners. Yes.
Just to not to forget, I always focus on the academics and the fellowship. But before I end my words, I just seek your wholehearted support for my candidature as vice president Foxy for the upcoming elections. The elections are in August 1st to 10th August, only for 10 days. That too online. It will take only 2 minutes of your precious time. So I request all of you to please vote and vote for me. Thank you so much. From West Zone, you have two posts. So in addition to me, you have one more choice to elect. Thank you so much.
Thank you, ma'am. Thank you so much.
Thank you, Sneha ma'am, and we all wish you the bestest of luck. That is always there, and you know it. That is coming from heart. So, uh, thank you and congratulations to all the quiz participants and winners. And Ishu, you were keeping it up quite well. Lost by few points, and that is like very immaterial. We all have learned quite a few things. And thank you so much, Dr. Nandini Jha and Dr. Samad Ilahi, for coordinating with me. Because of them, I could have completed this quiz for time and marks keeping. Thank you, Rakhi ma'am, and thank you, Sushma ma'am, and thank you, dearest Niharika, for being with me forever and always. And once again, Sneha ma'am, all the best for your every kind of endeavors. We're always there for you.
Thank you so much, dear. Thank you so much. Thank you.
Best wishes,
Yes.
Sneha ma'am. Thank you, ma'am.
Thank you, my dear Vartika. Thank you so much. Thank you. Bye
So we
bye.
all take your leave for today. Thank you and good night.
Thank you, all of you, once again. And I really, your wishes mean a lot to me. Thank you so much. Bye bye, Vartika,
Bye bye.
Shehla, Rakhi, Niharika.